welcome everybody. Thank you very much for coming to see this on a Saturday morning. It is raining outside here. I don't know what it's like where you are. Please tell us in the chat. And we'll be very jealous if you're on holiday somewhere nice and where it's sunny. Today we have the lovely Maggie Shepherd and the lovely Agnes, who are genetic diabetes specialist nurses. So just as we're starting to get more people join the live video, we will ask a couple of questions. So I am going to ask Agnes first.
Oh,
so,
hi everyone. Nice to be here.
Actually, should we introduce ourselves as well? I think we should, shouldn't we? But I'm a bit because my live video hasn't started on Facebook.
It's definitely live.
Mine's here, definitely.
Okay,
Yeah,
good. That's all right then, it's just mine then. Okay, so my name is Amanda and I'm a diabetes specialist nurse and I work in Medway in Kent. Vicky?
Yeah, I'm Vicky and I'm a diabetes specialist nurse currently working with the Eden team at Leicester Diabetes Centre. Diabetes specialist nurse currently working.
Oh, it's working now. Beth?
My name's Beth Kelly and I'm a diabetes specialist nurse currently in Southampton, but due to move to Wiltshire very soon.
Tamsin?
And my name's Tamsin fletcher-salt and I'm a diabetes specialist nurse at the Royal Stoke University Hospital.
And our special guest, Agnes?
Oh, hello, hi. I'm a diabetes nurse consultant working PCN in Poole.
And Maggie?
Yeah, hi, I'm Maggie Shepherd. So I'm working with the monogenic diabetes team down in Exeter. And prior to that, I was a diabetes specialist nurse up in London.
Wonderful. Okay, so our icebreaker question is, if you had superpowers, what would you choose? We'll go with Maggie first.
I'd love to be able to fly. No need to get on a plane, just head off by yourself. That would be ideal, lots of freedom.
Yeah, and not having to queue for airport security, that's definitely a good win.
I reckon you get loads of bugs in your face though, you know, like you want to...
that would solve the problem with the petrol.
You need some like goggles.
Yeah. A lot of windburn on your face.
Yeah, or like one of the COVID screen things would be perfect, wouldn't it? With some windscreen wipers on it. That's how high up you go, I suppose. Vicky, what would yours be?
I think I would like to be able to teleport and then I could just get to all the places I need to be instantly. That would be my chosen superpower.
That's a good one.
What are you thinking?
Me? I'm not really like a superhero person, so it's quite hard. I think I would choose the teleport one actually, because I spend so much of my time driving children to places and all that kind of stuff. It would be very helpful. Yeah.
Agnes?
Oh gosh, yes, both of your superpowers would be great, really. I'm about to go on the plane in 2 weeks, so teleporting would be fantastic. Maybe thinking about what we're going through at the moment, predicting, being able to predict the disasters and stopping it in the very beginning and just not having to deal with the consequences of it. So yeah, it would be great. Altogether it would be fantastic, isn't it?
Yeah, how all of them, you'd be like Superman. Tamsin?
Oh yeah, I think you guys have picked the best ones, haven't you, already? I think knowing what we're all going through at the moment with trying to get to places, definitely flying or teleportation would be a great one. But yeah, predicting what's going on in the future, or I don't think there is a superpower, but I'd quite like to go into the past actually. And
yeah, I was thinking time traveling.
Yeah, but
I wasn't sure if that's a superpower or whether that I don't know.
Yeah, I'd quite like to go into the past and do that sort of thing. But yeah, I think any of those of the above, if they were handing them down, I'd have one of them.
Brilliant. Okay, so I think we already have some bits in our chat that we want to ask you. So I'm going to start with Beth, if you want to start with the first questions.
Well, I think we were just going to ask one of you to not briefly, but as much as you want to say, like, firstly, what is monogenic diabetes and why you know, as diabetes specialists, should it be something on our radar and that kind of thing? And it's a huge topic, isn't it? So we don't expect you to go into everything, but just a little, as much as you want to kind of say.
Yeah, well, that's a great question, Beth, and a really important place to start. So monogenic diabetes, all that means is it's diabetes caused by a change in a single gene. So it's different from type 1 and it's different from type 2. But the sad point is that around 80% of patients who've got monogenic diabetes are initially misdiagnosed, quite often as having type 1 diabetes, because they tend to present with their diabetes young. So recognizing these patients is really important so that we can get them the specific right diagnosis for their diabetes and therefore the right treatment. So really that's the bottom line of monogenic diabetes and why it's important. And in fact, although people often think it's very rare, it affects around 4% of people diagnosed with diabetes below the age of 30. So really important to recognise.
Yeah,
I think I would like to add to what Maggie said, but also because sometimes clinicians would say, but what difference does it make that we, you know, they've got diabetes anyway, isn't it? But really so important about this crucial part about diagnosis, the right diagnosis. If it's not at the right time, when you should be at diagnosis, it's never too late to actually put it right, isn't it? So even if those patient or people with diabetes are classified or diagnosed already as having type 1 or type 2, you know, it's never too late to actually correct the diagnosis and let them have a proper treatment and information about the type of diabetes they have, really.
Yeah, because there's some of the types of MODY can obviously, as you say, some people might be misdiagnosed with type 1, which means they'd be using insulin therapy, but some of the types of MODY, they don't need to have insulin therapy and they can be switched to oral medications like sulfonylureas, for example. So I think that's the importance of the diagnosis, isn't it? And also for their future children and future generations and things.
And that is very important. So I think you can read loads of our examples in, you know, I would like to give a massive shout out to the team of genetic diabetes nurses that they probably down the chat because they really wanted to join, but they are joining live on chat. So
Yay!
I'm probably going to be typing the answers, which would be fantastic. So thanks for those who were able to join. But yes, there's obviously the team of Exeter, Maggie, and our genetic diabetes nurses team. We've put loads of example of case studies in journals, diabetes. So if you just type it, and it's, you know, very exciting to read about patients or people with diabetes who, following correct diagnosis of monogenic diabetes, have actually been changed to even from insulin to medication and achieving better control.
So what kind of things are we looking for? What would be your sort of red flag to make you think, oh, maybe this isn't the right diagnosis and maybe we should be looking at genetic testing?
Yeah, that's a great question too. I think the simplest to look for is our patients with neonatal diabetes. So these are patients who've been diagnosed with diabetes before the age of 6 months. Now, before people start thinking, well, I don't look after babies, I don't look after children. Actually, of course, these individuals grow up and they can be any age. So any of your patients, whatever age they are now, if they were diagnosed below 6 months of age, that's the only criteria we need to get them a genetic test. And just for example, we've got a patient called Jen in the northwest of England who was referred to us at the age of 43, but she'd been diagnosed with her diabetes just a few weeks of age. She'd been on insulin treatment for 43 years. By getting the right diagnosis by her DSN, realizing that yes, she'd been diagnosed below the age of 6 months, Jen was able to stop her insulin treatment after 43 years, transfer to glibenclamide tablets. She improved her HbA1c. She was able to lose weight. Her pre-proliferative retinopathy reversed, and she was able to get her HGV driving license, which she always wanted to get. So to be able to make that kind of difference for a patient is just fantastic. So that's absolutely the easiest category of monogenic diabetes to look out for.
Wow, that's life-changing, isn't it?
I would like to add about neonatal diabetes, how easy, because you may be feeling, oh, well, that's really, really rare. But I remember when I first started my training in genetic monogenic diabetes, I went back after 3 days of intensive training, knowing nothing really. I thought overwhelmed, but it was so fascinating. I went back to my diabetes center and simply ordered the database for age of diagnosis, and straight away came up with 11 patients diagnosed under the age of 1 year old. So obviously very excited about it, but some data may be put it wrongly. Sometimes, you know, database, they put the first day of the year for the diagnosis. But I found from those 11 patients, when I found the families, I found one which was actually diagnosed at the age of 3 months. And at that stage, she was 22, you know, all life on insulin, never knew different. And after the consultation, initial consultation and genetic testing, he was able to stop insulin. And it was just amazing. And that was my first patient. Without even going deeper into the training, I was able to identify it. So everybody could do that, you know, in their database and look for those people.
Oh, that's amazing. Thank you. So I guess the next question, which links quite nicely really, is how can those of us who are interested in monogenic diabetes, how can we go about learning more about it?
Yep. Again, great question, Vicky. So we're running a 2-day training course, which is virtual, on the 20th and the 21st of October, which I know Amanda's booked on.
We're not jealous.
As well as we've already got 300 other delegates registered, which is absolutely amazing. So all people need to do is just Google diabetes genes. You'll get to our website and you'll see the link for training there. It's free to register, so there's no cost to attend. And that's 2 days. It's about 4.5 hours per day of talks about monogenic diabetes, neonatal diabetes and MODY. Chance to ask questions to the experts. And those lectures will be available after that date online on our website as well, so that people who can't attend on those dates, they've got other commitments, they can undertake that training in their own time. And we're very keen for the more people to come to the training, the better, because the more people understand about monogenic diabetes, know how to recognize it, then the more patients we have with the correct genetic diagnosis. So just diabetes genes website and you'll find the training.
I've put the link in the chat, so it's there for people to use.
Fabulous, thanks, Beth.
If they want to look at it.
And is that part of the collaboration with NHS England and trying to obviously expand the opportunity for training?
Yeah, absolutely. So we started our national network of genetic diabetes nurses back in 2002. And that model, we had around 20 diabetes specialist nurses across the UK who were trained up in genetic diabetes, who then went across their regions trying to raise awareness. But the support we've had from NHS England's been absolutely fantastic. And the idea now is to get a DSN in every single trust trained in monogenic diabetes. So not only a DSN, but also a consultant to be a monogenic lead for their trust. So the idea is they'll attend the basic training, a couple of days worth or 9 hours or so worth of training in monogenic diabetes, so that it doesn't matter where the patients are, that they've got a really good chance of having somebody who's going to recognise that they've got an unusual genetic type of diabetes. And it's the financial support from NHS England that's allowed us to enable that training to be free.
Amazing. So I think me and Tamsin have a similar sort of question. I was going to say, as you were talking about Jenny, it just kind of came into my head that, you know, you said she switched from an insulin to sulfonylurea. So those kinds of patients, are they, do you find them more kind of, they really struggle with insulin therapy? Because, I mean, I know most of our type 1s do as well, but is it even more difficult to kind of get good sort of management with it, because obviously that's not the right sort of treatment that they require? So can you tell, like, I suppose, like Tamsin was her next question, it will go into Tamsin's question, I suppose. Is it something as DSNs we can sort of look along with all the other history, but can you see sort of patterns or something in their sort of diabetes management, I suppose, that kind of would highlight it, if that makes sense?
Yeah, that's quite a tricky question to answer with all the different types of monogenic diabetes. We've identified around 33 different genes that cause different types of monogenic diabetes. Obviously this morning we won't have time to talk about all of those, but I can certainly talk about the commoner types. So HNF1 alpha, that's one of the genes that causes MODY, as it used to be called, and those who've got a change in the HNF1 alpha gene are very sensitive to low doses of sulfonylureas. So they're much better managed on just, 40 milligrams of glycoside once a day, that kind of dose, rather than insulin. So they'll get much better glycemic control, much more stability with their blood glucose levels than they ever would have on insulin. And there's another type of, another genetic change in the gene, the glucokinase gene. Those patients actually don't need any treatment at all. And again, so that's why it's really important to recognise those patients, because they can actually be discharged from diabetes services. But all the different genes have slightly different treatments and recommendations. But the only patients with monogenic diabetes who tend to need insulin are perhaps those who've had diabetes a long time, got a long duration of diabetes, and then quite often they'll need a basal, just a once daily basal insulin in combination with a sulfonylurea, and that's with the patients who've typically got HNF1 alpha or HNF4 alpha MODY, but they won't need the 4 times a day basal bolus regime that you typically see, or your pump therapy that you'd see in your type 1s.
Yeah.
And I suppose just adding to what Maggie said, so glycemic control not always going to sort of shout out to us that this patient may have MODY. That's why, excluding the neonatal diabetes, which is very easy to diagnose, this is where it becomes a bit tricky. That's why we would like, each team to have a monogenic leads to be able to pick these people from your clinic. So, things like family history, hypoglycemia or on small doses of SUs, or all sorts of things that could actually start you thinking this is not typical type 2 or typical type 1. So yes, glycemic control not necessarily is the first who's going to say, oh, because of this, you may be MODY. So all the criteria are now published on NHS England and the Exeter website, so you can have a look, and after the training you could possibly be more prone to look into the clinic and find out patients that meet those criteria.
Yeah.
Tamsin, you was next, wasn't it?
You've already said that it's a huge area in a sense. There's so many genes that now could affect whether how they're diagnosed with diabetes, really. But there's family history, obviously, that we need to look at, isn't there? I think that I'm quite lucky. I have we have a DSN in our team who did your genetic courses, I think probably back in the early 2000s. So if we have any queries, we're usually on the phone or on our phones asking the question. But for those teams that perhaps don't have somebody in their team who they can go to about it, what sort of things are they looking for with regards to sort of family history and things like that?
Yeah, the very simplest question to ask is, does that individual have a parent with diabetes? So for the majority of cases of MODY, we'd be looking for an individual who's diagnosed below the age of 25 with an affected parent or affected child, because it's what we call an autosomal dominant inheritance, which basically means if you pass on a copy of that affected gene, there's a 50% chance of each child inheriting that affected gene. So it's kind of handed down from a parent in one generation to the next, so it doesn't skip a generation. So anybody that you've got within your service who was diagnosed below the age of 25 and has a parent or a child with diabetes, then we'd at least be thinking, okay, shall we look a little bit more? So for example, in those cases, because of course you get familial type 1, you get familial type 2, you'll have a parent who genuinely has type 1, who genuinely has a child with type 1. But if that's the scenario, well, we'd be looking to see, well, have they had pancreatic antibodies tested? Which, if they're positive, then that fits with a diagnosis of type 1 diabetes. But again, we'd be looking for a broad spectrum of pancreatic antibodies to be tested. So we'd be looking for GAD, IA2 and zinc transporter antibodies to be tested. Because in fact, in children, to be IA2 positive is more common than to be GAD positive, and not all labs will test IA2. So if you've got a parent and a child with diabetes, then we'd be at least looking, okay, could this be a genetic cause of a single gene that's caused the diabetes in the family? And you can test that by other things like antibodies, or if someone's had long-standing diabetes, you can measure C-peptide to see if they're producing insulin of their own, because those with type 1, after the honeymoon period, after a period of time, you're not expecting them to carry on making their own insulin, whereas those with MODY will do. So just the simplest question of, have you got a parent with diabetes? And quite often people will then say, oh yeah, well, I've got a parent with type 2, or I've got a parent with type 1, but we'll always kind of just investigate that a little bit further rather than taking that at face value.
Is there any difference with regard to gender? So does it make a difference at all? No.
No, none of these genes are on the X or Y chromosome, so equal chance of men and women to be affected. The only one that's slightly different there is with maternally inherited diabetes and deafness, or MID, you might have heard of, where individuals have diabetes, but they also tend to have a bilateral sensory neural deafness. And that's where the mutation is passed on in the mitochondria, and we get all our mitochondria from our mum. So mums can pass it on to boys and girls, but the boys can't pass it on. It's only the women that can pass that on. That's the only exception, but otherwise it's not influenced by gender.
Also just adding what I first learned, so just to ease the process for people, when I first, we were told similar to what Maggie said, but the other way around. So if you have a patient with diabetes who has no parents affected or both parents affected, this is less likely for them to have monogenic diabetes. So straight away, because we get excited, isn't it, when people come, especially now with the more and more people having a young onset of type 2 diabetes, but they're very likely to have family history of both sides. So I get referrals because people get excited, and could this be MODY because it's a young onset? And similarly to those who may have sporadic type 1 diabetes across the family but not in parents. So yes, so just looking on one side of the family, paternal, maternal, mum or dad, and down or up, sort of helps to sort of get your thinking process.
And I think you've raised a really
somewhere though, doesn't it?
Yeah, absolutely. And we do have individuals who don't have a parent affected. I mean, they're slightly rarer situations, but yeah, absolutely, we do. You're right. The genetic change has got to start somewhere. But I think you brought up a really important point there, Agnes, because obviously making the right diagnosis is quite complex these days. You've got people from different ethnic groups where it may be easy to just assume, oh well, this is young onset type 2 diabetes, and yes, it may well be more likely to be that, but it's important to consider BMI as well, because obviously a lot of those with early onset type 2 diabetes may fit in the either being from a different ethnic group or being having high BMI. But it's kind of important to look at, it's like putting a bit of a jigsaw puzzle together. Don't just think about one characteristic. It's like put all the information together and see what fits with the most likely diagnosis. But I think what can really help is the Exeter Diabetes app. So I think someone was going to ask a question on that one. I think we were going to ask about that one, Beth.
That's okay.
Go for it.
Yeah, so just if anyone hasn't come across it, either on our Diabetes Genes website, there's a MODY calculator, or you can just download on your phones for free the Exeter Diabetes app. And you can do this literally with a patient in front of you. It literally takes a few seconds.
Yeah, it's so easy. Oh, you can't see it on there, but
got a bit of...
You just input in the patient's current age of diagnosis, treatment, is there a parent affected, BMI, a few other criteria, and then you click on calculate probability, and it'll give you a score of how likely it is for that patient to have monogenic diabetes. I don't know if Agnes can talk about her experience of using that, but it's really quick and simple to use.
Very quick, and what's also very helpful is that it gives you, so it's not only to help you to identify a patient with monogenic diabetes, but also help you to diagnose your patient with diabetes, because it will give you the differentiation diagnosis, or where to look for, or interpret your results of antibodies or C-peptide, and also give you a nice link to the website, to more resources to look for. So it's not just simply, you know, calculator, which is really handy, really helpful. I use it all the time because I get too excited about it. I could see, you know, monogenic in every single patient, so I need to calm down. But it is very helpful, and it's at the, you know, it's on your phone. So it's web. So the Exeter Diabetes is a web-based app. So you have to open it up on your phone and send it to your screen, and it works beautifully.
Yeah, Beth's put the link in the chat in the Facebook group, so anyone can get that from there.
Brilliant.
Speaking of the group, there is a question that's come through. Is there a link with gestational diabetes at all?
Yeah, again, that's a good question. So often our patients with a mutation in the glucokinase gene get picked up gestationally. So a change in the glucokinase gene means that people's blood sugar is just set slightly higher than somebody without diabetes. And for a lot of women, when they're pregnant, that's the first time they may have their glucose detected. So often in pregnancy, unlike gestational diabetes that often gets picked up in the last trimester in people who are perhaps more likely to be overweight, glucokinase often gets picked up in the first trimester. So this is where you've got slim individuals who will have a slightly raised fasting glucose or a slightly raised 2-hour glucose. And again, those patients are really important to pick up. But also the management of monogenic diabetes in pregnancy is really important to know about, because one of the genes, HNF4 alpha, can cause macrosomia much more than you'd see in just any other type of diabetes, and can cause severe neonatal hypoglycemia. So again, thinking about patients when they're pregnant is really important, but that often you would pick up gestational, you'll pick up glucokinase when people are pregnant. So that's a really good question.
And also looking at the family history in glucokinase, especially in the pregnancy, it's not unlikely that it may be that the family history is not picked up because it doesn't cause any symptoms. And if parents or grandparents have never been tested, that individual won't tell you they've got family history. We're usually looking at this criteria. We've got separate criteria set for glucokinase in pregnancy, so you can look for those with lower BMI and age and fasting blood sugar levels. And really, that just, it could be the start point when you actually diagnose glucokinase in that first individual in the family, and then you can test other family members.
Very interesting. So I suppose diabetes specialist midwives might be good to attend your training session so that they can learn all about these different types of things that they might find in pregnancy. Beth, was there any other questions on the Facebook group or any other ones through?
I've got one, if that's okay.
Yeah.
It was just with regard to if somebody does need to have the genetic testing, how do they go about doing that? Do they need to be referred into a specialist service, or can it be done in the community?
Yeah, it's made much more simpler now. So the cost of testing is now centrally funded. That's how we describe it. So that means that the cost of the test won't be charged to the GP or the diabetes service. Again, on our website, Diabetes Genes, there's just an A4 form which can be downloaded, which should be sent with a sample. So that's a referral form for genetic testing. So the blood sample can get taken anywhere through the patient's GP or through the patient's diabetes service, sent through the post with this form to us, with no cost for the testing for anyone who's based in England. And the tests will take about 8 weeks to get a result. It's like looking for a spelling mistake in the library full of books, is how they describe it. So it's not like a quick test like an HbA1c that you'd expect a result in a week. It can take about 8 weeks to get the result. And also on the website, you'll see the criteria for genetic testing. So there are particular criteria that people need to meet, because obviously we don't want to be testing lots of people who were diagnosed elderly and happen to have, you know, a strong family history. We're really looking for those individuals diagnosed below the age of 25 typically. So that's the patients will need to meet criteria, but getting the test done is actually very straightforward. And
worth to mention maybe that before you consider genetic testing, there are if you non-genetic or pre-genetic testing, you can, like Maggie mentioned before, antibody screening or C-peptide if it meets that criteria, or even fasting blood glucose so to be sure that your test's not going to be, sort of turned back, because we want to identify those people with genetic form of diabetes. So if you suspect it may not be type 1, then maybe antibody screening before you send, or C-peptide if it's 5 years post-diagnosis, or with glucokinase if you suspect, those simple results of fasting blood glucose or GTT results, just to be there as well before.
So if the antibodies are positive, then it's not going to be MODY. That's what we're getting at.
Differential, yes. So if the positive antibodies, it means type 1 diabetes. So even if there is all the criteria, you wouldn't screen for monogenic diabetes.
Yeah, it'll be interesting to see maybe if, because I know we were all yesterday at the EASD, so we saw the ADA and the EGS, I can't say that word,
type 1
EASD type 1 consensus. Yeah, so now they've suggested the cascade antibody testing. It might be interesting to see if we start to pick up potentially more cases of monogenic diabetes, because I don't know, but back when I started, it was more of a case of, well, if it looks like type 1, it probably is, and now we've got much better at doing the antibody testing and C-peptides and things.
Because NICE guidelines did say not to test everybody routinely.
Yeah,
So
they just said if it looks like a duck and that
cracks like a duck,
then it's type 1.
Yeah, that's quite challenging. I mean, I think, in children, 95% plus of children with diabetes will have type 1. So you'll be right in 95% of cases, but those 5%, who may have early onset type 2, may have monogenic diabetes, etc. It's really important to recognize those individuals because they've got a lifetime of diabetes ahead of them.
Yeah.
So, we take the point that actually, we can see both sides of the argument, if you like, but I think we did some work with a Swedish group looking at the whole of their pediatric population. And what we did there was all the pediatric population was screened for 4 antibodies. And then those that were negative automatically went on for genetic testing. And then, because of course you can get antibody negative type 1 diabetes, but in the Swedish population, all of those who were antibody negative, 25% had a monogenic cause of their diabetes. So if they were antibody negative at diagnosis, we then went on and did genetic testing, and 1 in 4 of them had a monogenic cause of diabetes. So, another way some services have gone about it is by looking back at, okay, well, who's had antibodies done in our pediatric population at diagnosis? And actually, if they've come up negative, should we be looking a little bit further? Should we be thinking a little bit more about them?
Yeah, that's really interesting.
Tamsin, I think there's a question from Facebook, is there?
There is, yeah. Somebody's asked, should parents have counselling with regards to genetic testing?
That's an interesting question. I suppose it depends which context that question is being asked in. So what we tend to say, if somebody's got diabetes and we're doing a genetic test to find the cause of their diabetes, we don't really offer what we'd call kind of full genetic counselling for that, because actually we're doing a blood test to see what's the cause of their diabetes. We will talk about the fact that if it comes out to have a genetic result, then that's got consequences for their children, etc. But we will do, if a parent, say, has got HNF1 alpha MODY, and they're talking about asking to test their children who don't have diabetes at this point in time, whether they've inherited the affected gene and therefore will go on and develop diabetes, then absolutely we would offer genetic counselling to that family, to the parent and the child of that family. So again, it's quite different depending on the situation, if you like. But if someone's already got diabetes, then really we're just explaining the cause of their diabetes, but we'll talk around the possible implications of the result before they have the test.
Yes, so from my practical experience, I have referred a couple of families for the predictive testing before that happened, because children were quite young and parents were insisting on having a test for the children, but really wanted that family to understand, because obviously both children could have it, both could not have it, one could have one. So many scenarios, and wanted them to realize, you know, how that life of that child could change or be affected before they even get the symptoms. So it's called like predictive testing. So it's very individual approach to the families, isn't it?
I think there was a sort of a question on the Facebooks about a patient, a lady with gestational diabetes, high BMI, but mum has type 1. So I think they're asking you, what would you do in that case? I think personally, I'd probably send off for antibodies and just double check.
Yeah, so again, you know, a very easy, quick thing to do is put those details into the probability calculator or the Exeter Diabetes app and see what the score comes up with, because that'll ask some other questions that we don't have the data on from the question here. So, you know, if you're not sure, always put something into the probability calculator or the diabetes app. That's a very good first starting point. And then I'd be asking kind of other questions. I think it's a bit like being a detective. You know, you'll be asking, okay, well, what's the ethnic group? How do we know mum's got type 1? How did she present? You know, has she had antibodies tested? Has she had C-peptide? Are we sure that mum really is type 1, or was she just always on insulin from diagnosis? And then the person who's got the gestational diabetes, again, I'd be looking, well, how did she present? How was she picked up? We don't want to exclude her just because she's got a high BMI, but, you know, do her characteristics fit, for example, with glucokinase or with one of the other types of MODY. But yeah, go to the probability calculator or the diabetes app as a first port of call.
Yeah.
Does ethnicity, is ethnicity a reason why you would check somebody, or does ethnicity not have any, you know, any link to?
Yeah, no, it's really important question. So Shivani Misra, who's now at Imperial, when she was working with us, has done some great work in looking in South Asians particularly, and the prevalence of monogenic diabetes in South Asians. And absolutely they can get MODY and monogenic diabetes, but interestingly they tend to present even younger than their Caucasian counterparts, and they tend to be even slimmer, so even lower BMI. So again, it's a little bit harder to differentiate some of those patients who've got a high likelihood of an early onset type 2 diabetes, but absolutely they can have monogenic diabetes as well. So it's important that we don't just discount them as being unlikely for having monogenic diabetes. But Shivani's done a great paper on that if anybody wants to look that up.
We'll try and find it and put it in the chat.
Yeah, I'll see if I can find it.
Yes.
I've got a question. So once a patient's been diagnosed with monogenic diabetes, you said some can be discharged. So will they still need to go for their annual review checks, all the screening and things? Would DSN still keep them under our team? Would they then go to a specialist like GDSNs for their clinics, or where do they go?
Yeah, so the only, sorry, Agnes, do you want
go
to take
ahead,
that one?
Go ahead, Maggie, I will add on if I want to.
Yeah, so the only patients that we would discharge from a diabetes service are those with glucokinase MODY. All the rest, 1 alpha, 4 alpha, neonatal diabetes, HNF1 beta, etc., we'd absolutely keep within a specialist service. So that could either be within, we've got 10 monogenic clinics running across the UK, that could be within one of those, or with the idea that if we're getting consultants and diabetes specialist nurses trained up in monogenic diabetes, then they might be able to look after them within secondary care with a bit of support, either from their local genetic diabetes nurse or by ourselves in Exeter. Did you want to add to that, Agnes?
Yes, just to add, yes, so what Maggie said about glucokinase, so this is the only type, but we do inform the families and the clinicians that they should really come back to us if they're planning the pregnancy, and never ignore the dads. So also dads with, you know, glucokinase, when they're planning the pregnancy, this is the only time when we would like them to be in the clinic, because obviously depending on the baby's phenotype or whether they've inherited the mutation or not, that could impact the way how the pregnancy goes. So, but the families are very much, we always get this question, isn't it? Every time I diagnose somebody with glucokinase, what do we do? Shall we leave it? And sometimes families insist to stay because they get this free of charge, you know, MLT, a checkup at GP center every year, but they don't have to be in the clinics. But I've got 50-50 really. So, some say, oh, that's fine, we'll just leave it. Some want to come and have the HbA1c check, because I think they just maybe feel a bit unsure, because it's quite a big concept for the families, isn't it, to understand genetics. Like for us, really, is something that is coming to the practice more and more, and hopefully with the changes to our services is going to be a you know, everyday practice we do. But can you imagine the families, you know, being informed about it?
I suppose
to digest it.
If they've had insulin therapy for most of their life, and then you've just been told, no, you don't need to do that or something anymore, it's a huge change. And you can imagine perhaps they might not trust what they've been told, or, you know, just because they've already been told something that was wrong once. So yeah, it's probably a big change to go from lots to nothing.
But it's really important to flag up that patients with HNF1 alpha and HNF4 alpha MODY, that are the commonest causes of MODY, it's vital that they have their annual reviews. They're absolutely still at risk of the same complications, microvascular complications of diabetes that our patients with type 1 are. And in fact, our patients with HNF1 alpha are prone to early MI and need early treatment with statins and things. So it's really important those patients get annual follow-up. And the patients with HNF1 beta, that's characterized by a renal developmental abnormality as well as diabetes. So it could be renal cysts or a single kidney or a horseshoe kidney with diabetes. And again, those patients need to be closely followed up in terms of renal function. We tend to do fecal elastase because often they have a very small pancreas and they need treatment with Creon, they get pancreatic insufficiency. So absolutely, I would say the vast majority of our patients with different types of monogenic diabetes need annual follow-up and specialist review for sure.
Right, and I don't think we've got any other questions apart from the ethnicity study by Shivani. We'll find that out, and we'll put a link in the chat when we work it out.
We'll tweet her. She's on Twitter. So
yes.
Oh yes.
It won't take me a minute to find it. I'll just try and look that up.
Yeah. So as long as there's no further questions, I think we'll say thank you to our special guests. Thank you very much, Maggie and Agnes.
Sorry, can I just?
Yeah, there's lots of questions.
One question. With regards to treatment, we talked about like using sulfonylureas, but is there any scope for using sort of the newer therapies, so like the SGLT2s and the GLP-1s in these patients?
Yeah, again, that's a very good question. We don't have an awful lot of data to rely on. Our patients with HNF1 alpha tend to have a low renal threshold for glucose. So if you want to use SGLT2s in those, they need to be used with caution because they have this low renal threshold for glucose anyway. So we need to be cautious about, you know, causing dehydration, etc. But we have had some experience with those in some individuals who've done okay. We've also got some anecdotal experience of use of GLP-1s in HNF1 alpha, and again, in some patients that's worked well. But there's a bit of a lack of data out there, and so that's especially the new agents have, you know, have come in relatively recently, and we would need to do a proper kind of randomized control trial in terms of seeing how our patients with different types of monogenic diabetes fare. Our patients with HNF1 beta typically need insulin. They tend to have a tiny pancreas and can't manage without insulin. Our patients with MID tend to need insulin within 2 years. So really, and we know our patients with the commonest causes of neonatal diabetes manage well on high dose sulfonylureas. So it's really just our patients with 1 alpha and 4 alpha where we're thinking, okay, may there be a need for another agent? But typically we'd use a low dose of sulfonylurea first. If we need to add to that, we typically use metformin. If we need to add to that, then we'd think about one of the newer third line agents. But as I say, quite often it's a question of just, well, let's try it in those patients and see how we go. And I've just found the link for the paper, so I'm going to pop that in our little chat here, and someone else can probably put that onto Facebook.
I was going to say, I think someone's already done it.
Oh, have they? Someone beat me to it. Well done.
What I wanted to add is just obviously with less and less use of sort of like glycoside in the practice for type 2 diabetes. I think in the past you could be just that first you know, thing that comes up when the patient experienced massive hypos on low dose of sulfonylurea. So now it's going to be even more difficult with the use of the new agents instead. You know, that sort of thing, you know, that sensitivity to SU is going to be less and less seen because we don't really start this often. But if it does happen, then obviously you may think about managing diabetes. Yeah. But I just wanted to add the last thing. So obviously, with knowing that my colleagues, other GDNs are there in the chat. So with the new changes to the genetic services, each secondary care team should have received a letter about identifying their own local, for their trust lead consultant and DSN. So if they haven't, if there's any diabetes nurses there who haven't heard anything, or from the colleagues that they've actually have received the letter, if they just look because some trusts, they may not have a local GDN in place, so we have been sending letters to whoever, we found the contact details maybe. So if you, any of the DSNs are there and haven't heard anything about it, if they just contact either Maggie or myself, we could direct you to the GDN who's looking after that area and get that going, because there's still time to book for the October study days. So if you have got that and identified your leads, fantastic, but we want to hear from those who maybe haven't.
Yeah, I think, do we have a link to you guys on our website as well? Because we were going to ask, how can you find your local genetics diabetes specialist nurse if you have one, or how, if you're new to a role, how would you get in touch and things? So obviously you can go to your website. Would that be the best place to go? Or?
That's the best place, but it'd be great if you wanted to put a link to our diabetes teams.
I think we already have,
website.
But we'll double check. Yeah.
If you want to find your local genetic diabetes nurse, just go to the training section on our Diabetes Genes website, and that's where you'll find the access to the course as well. But as Agnes says, any DSNs who'd like to learn more, and it's just we just see it just as a DSN somebody may take a lead for the pregnancy within their service, somebody may take the lead for the pump patients within their service, somebody may take the lead for the inpatients. It would just be like that, somebody taking the lead for the patients with monogenic diabetes. So, and we really want, people trained within every single trust. So we'd be delighted if people want to kind of join. And I think it's such a rewarding area to work in, because if you can get the right diagnosis for those patients, then it's absolutely life-changing. And that's a fantastic thing to be able to do as a DSN, to really make that difference for not only with that one individual, but for their family as well.
And so if you have a diabetes specialist nurse in your area, so like we have Paula Johnson in our area, but I wanted to do it as well, are you allowed to have more than one? Are you just welcoming anyone now to come and, because I know before you had that kind of contract where you would get sort of your time backfilled and things, so is it now just a bit of anyone can come and?
Yeah, so the more the merrier, I always say. And in terms of the question about, diabetes specialist midwives training, absolutely. Also pediatric teams, also dietitians, anyone working within diabetes who wants to train up, that's great. And in fact, you can have more than one or two individuals within each trust who are trained. If more people want to come, that's absolutely fantastic. We tend to encourage one to take up the kind of lead role, if you like, but the more people want to come and train, the better. But because this is not asking individuals to take on a role outside their own trust, then there's no funding associated with it. The training's for free, but it would just be your work within your own DSN role, because these patients will be in your service anyway. You will be looking after these patients anyway. It's just they may not have got the right diagnosis.
Yeah, because we're all seeing different patients, aren't we? That is said, the patients that I see are maybe in a community, whereas Paula works in like the acute trust where we refer in and things like that. But it's good for the more people can have eyes out, the better, I think. So
yeah, absolutely.
Cool. Anything else you guys wanted to say? I think there's no other questions, but is there anything we've missed that you were burning?
There's just Barbara says it's very sunny in Australia.
Fantastic.
Very rainy here.
We're all very jealous, Barbara. We want to come for a holiday.
Oh, how lovely her joining us for a holiday. Yeah, brilliant.
It's probably time for bed for Barbara in Australia, isn't it?
Yeah, it must be late there actually, or early. I don't know how that works. No,
lots of people saying thank you, very interesting talk. Thank you, everybody.
Thank you for having us.
That's great. I mean, thank you very much for having us. We're absolutely delighted to be able to come and share some of our enthusiasm about monogenic diabetes, and really hope to see you guys at our training either in October or doing that virtually online at some other time.
Cool. Thank you so much, guys.
Lovely. Thank you, everyone.
Thank you.
Bye.
Thank you, guys. Bye. Have a lovely weekend.
Thanks for watching, everyone.
Thanks, everyone. Bye.